All right, so we are doing COPD. You watched a couple of videos, and I bet you they were long, especially with Sarah, but I like how she really breaks it down. Even though it's longer, it's fine. So COPD, I wanted to go over some of the questions she had on my test bank. It didn't have like any fucking questions. So, all right. So, true or false, COPD is reversible and tends to happen gradually. So it's going to be false. COPD is irreversible and tends to happen gradually. So asthma would be the one that is reversible. It can't be exactly cured, but it is reversible. So 2, a patient is presenting with chronic obstructive pulmonary disease. The patient has a chronic productive cough with dyspnea on exertion. Arterial blood gases show in low oxygen level and high carbon dioxide level in the blood. On assessment, the patient has cyanosis in the lips and edema in the abdomen and legs. Based on your nursing knowledge and patient symptoms, you suspect the patient suffers from what type of COPD? So is it A, emphysema, B, pneumonia, C, chronic bronchitis, or D, pneumothorax? So C is going to be that chronic bronchitis, so blue bloater, So the answer is C. The key word to know is that the patient is experiencing chronic bronchitis or cyanosis and edema in the abdomen and legs. Remember, chronic bronchitis is sometimes referred to as blue bloaters. Okay, so a patient with emphysema may present with all of the following symptoms except A, a barrel chest, B, hyperinflation of the lungs, C, hypoventilation, D, hypercapnia. So the answer is C again. So patients with emphysema present with hyperventilation. They're called the pink puffers, right? They breathe fast. So the body will try to compensate for the low oxygen blood levels and will cause the patient to hyperventilate. So remember, emphysema patients are also called pink puffers. They will have a barreled chest because they're using that accessory muscles for breathing. Hyperinflation of the lungs is due to the damage of the alveolar sacs and the creation of air sacs. And hypercapnia, which is that trapping of that high carbon dioxide levels. The term blue bloaters is used to describe patients with what? A, pulmonary hypertension, B, left-sided heart failure, C, chronic bronchitis, or D, emphysema. We just said it, so it is C, chronic bronchitis. So a patient is newly diagnosed with COPD due to chronic bronchitis. You're providing education to the patient about this disease process. Which statement by the patient indicates they understood your teaching about this condition? So A, if I stop smoking, it'll cure my condition. B, complications from this condition can lead to pulmonary hypertension and right-sided heart failure. C, I'm at risk for low levels of red blood cells due to hypoxia and may require blood transfusions during acute illness. Or D, my respiratory system is stimulated to breathe due to high carbon dioxide levels rather than low oxygen levels. Might as well charge my other things. So, I don't know if you actually heard all of that. So the answer is B. Complications from this condition can lead to pulmonary hypertension and right-sided heart failure. So this is the only correct statement. Option A is wrong because smoking cessation will not cure the condition, but it may slow down the process of it. So option C is wrong because the patient may develop high levels of red blood cells due to the body trying to compensate for hypoxia. And option D is wrong because patients with COPD are stimulated to breathe due to low oxygen levels rather than high carbon dioxide levels. I think that might be all. No. Okay, so an alarm beeps notifying you that one of your patient's oxygen saturation is reading at 89. So the oxygen saturation rate, I believe, would be like 95 to 100%. Is that, I don't know. So you arrive to the patient's room and see the patient comfortably resting in bed watching television. The patient is already on 2 liters of oxygen via nasal cannula. The patient is admitted for COPD exacerbation. Your next nursing action would be A, continuing to monitor the patient, B, increase the patient's oxygen level to 3 liters, C, notify the doctor for further orders, or D, turn off the alarm setting. So the correct answer, I got this wrong. I said notify the doctor for further orders. But the answer is A, the patient is not in any distress from the description provided. Therefore, you would continue to monitor the patient. So it would be A. So patients with COPD are stimulated to breathe due to low oxygen levels rather than high carbon dioxide levels. Therefore, it is normal for patients who have COPD to have an oxygen saturation between 88 to 93%. Any higher would decrease the stimulation to breathe, and they may stop breathing. Geez, I did not know that. So patient with COPD, it's stimulated to breathe through low oxygen levels, not high carbon dioxide levels. So any higher would decrease the stimulation to breathe and may stop breathing. Therefore, you would not increase the oxygen level to 3 liters, notify the doctor, or turn the alarm settings off. You are providing teaching to a patient with chronic COPD on how to perform diaphragmatic breathing. This technique helps to do the following. A, to increase the breathing rate to prevent hypoxemia. B, to decrease the use of abdominal muscles. C, to encourage the use of accessory muscles to help with breathing. Or D, strengthen the diaphragm. So it would be D, to strengthen the diaphragm. So the answer is D. Diaphragmatic breathing helps strengthen the diaphragm because it has become flattened due to the hyperinflation of the lung. Due to the flattening of the diaphragm, the body is unable to breathe with ease and must use the accessory muscles to compensate. Therefore, diaphragmatic breathing helps decrease the breathing rate to prevent hypoxemia. Increases the use of abdominal muscles rather than accessory muscles, which strengthen the diaphragm. Then they go into about like all this medicine, and we're not in pharmacology right now. Let me read some of her notes about it. Okay. Key points for COPD, limited airflow. Why is there limited airflow for COPD? So with COPD, this is due to thick and swollen bronchioles that have become deformed with excessive sputum production, that this narrows the airways. Also, they have a inability to fully inhale or exhale? They have the inability to fully exhale due to the loss of elasticity of the alveolar sacs from damage, and the sacs start to develop air pockets. Is this irreversible or reversible? This is a irreversible disease, and then managed with lifestyle changes and medications. Does this happen like out of the blue? Does this happen spontaneously? No, this happens gradually. So most people start to notice signs and symptoms like around their middle age and will present with dyspnea. So having trouble breathing with activities that they would normally are fine with. And then having recurrent lung infections and chronic cough. COPD is a term used as a catch-all phrase for diseases that limit airflow and causes dyspnea. So COPD is a this, like what it says, like an obstructive lung disease. Asthma is another destructive lung disease. Emphysema, chronic bronchitis. What else did they say? Yeah, and that's pretty much it for the chronic obstructive. I think we have more of the, what was the other one that we had? Restrictive lung diseases. So types of COPD include emphysema, the pink puffers, because they're breathing really fast, and then you have that, they use the accessory muscles, and this, again, like when we were talking about, is that they get stimulated to breathe because of low oxygen levels and not high carbon dioxide levels. And then we have chronic bronchitis, which is the blue bloaters, and this is going to be where they are like, you know, they turn blue or cyanosis, and they also have edema around their abdomen area and their legs. So what happens in breathing with COPD, with chronic bronchitis? So the name blue bloaters is due to cyanosis from hypoxia and bloating from edema, an increase in lung volume. So the bloating is from the effects of lung disease on the heart, which causes right-sided heart failure. In chronic bronchitis, the bronchioles become damaged that leads them to be thick and swollen and deformed, which is, there's an increase of sputum production. This limits the ability for the person to completely what? Inhale or exhale the air taken. So completely exhale the air that was taken in. So when they take another breath in, it will increase the air volume even more, because they have retained air from the previous breath, which leads to hyperinflation because it's trapped. Also, less oxygen is getting into the blood and more carbon dioxide is just accumulating, which leads to low blood levels, low oxygen blood levels, and high carbon dioxide levels. So to compensate with chronic bronchitis, the body's going to increase red blood cells, you know, to allow for more oxygen. So it's trying to figure out, like, to solve the problem. But shifting elsewhere, which increases pressure in the pulmonary artery, leading to pulmonary hypertension. So now we are causing another problem, even though we're trying to help out because we're trying to make more red blood cells. But that wasn't, like, the problem, you know? And so now we could have that because now it's thicker in blood. You know, our blood is like thicker. Now it's even making it worse for the heart to pump that because now it's so thick. Now it's hurting the heart. So in conditions as emphysema or the pink puffers, this comes from the hyperventilation or puffing to breathe and pink complexion due to the rapid breathing that rather than cyanosis in chronic bronchitis. So in emphysema, the alveoli sacs lose their ability to inflate and deflate due to the inflammatory response in the body, so the sac is unable to properly deflate and inflate. So then you have, you know, inhaled, so the air is trapped in the sacs. And then this causes major hyperinflation of the lungs because the patient is retaining so much volume, which then flattens the diaphragm, which I believe it says like 80% of the diaphragm helps us to breathe. And then because the diaphragm is affected, we're using accessory muscles within the chest, which then gives that bare chest look. Okay. And so the signs of symptoms of COPD, it says lung damage. So L for lack of energy, U for unable to tolerate activity or shortness of breath, N for poor nutrition because it's so hard to breathe. Have you ever been sick where it's like so hard to breathe, like you don't even want to fucking eat? Like I was so stuffy that I had to like take a really good breath before I could even like eat anything and swallow it, and I would have to eat it really fast. And that's what they're saying here. So they said weight loss due to the energy used and breathing, especially with emphysema, like it's just very difficult. And so like they just don't eat a lot, you know, especially if it's that severe. So gases are abnormal. So POCO2, so that's going to be more acidic, right? I would think. So yeah, so acidosis. So you're going to have more hypercapnia. Anyways, so with POCO2, it's 35 and 45. So anything above 45 is going to be that acidity. And with POO2, the pressure artery of oxygen lower than 90. So abnormal lung sounds like diminish, coarse crackles or rails, and wheezing. Modification of skin color like pink or blue. So the anterior posterior diameter shows barrel chest. Also, of course, like if you're having a hard time breathing, get into that tripod position, get up, you know, with the high flowers. Extreme dyspnea. So complication of COPD is heart disease. Pneumothorax, spontaneous due to the forming of air sacs. Risk for pneumonia and cancer. How is COPD diagnosed? So COPD is diagnosed with a spirometry. I don't know what it's called, but it's SPIROMETRY. So it's a test where patients breathe into a tube and measures how much volume the lungs can hold during inhalation, and how much and how fast air is exhaled. Yeah, but I think that's it. We've done enough.